Now for her presentation. Thank you, Jen.
Hey, can you guys all hear me okay?
Yes, I can hear you.
Okay, perfect. And you can see my screen, I assume. All right, so we'll get started. I am going to talk to you guys today about the duration of dual antiplatelet therapy, where we're at right now, where we've kind of come from, and where we are headed in regards to this topic. So we'll start with the true minimums here, stuff that we're all very familiar with. We know that aspirin is an irreversible inhibitor of cyclooxygenase 1, and we know that it plays a critical role in the synthesis of thromboxane A1. However, we also know that aspirin interferes only partially with the inhibition of platelets, and if they remain responsive to external stimuli such as adenosine diphosphate, which is released in the bloodstream with vascular injury. And so we of course know that patients on chronic aspirin therapy still have residual platelet reactivity and thus can have a significant rate of cardiovascular events, which highlights the need for a second additional agent. In 1987, clopidogrel came about, and we have since, of course, added that to aspirin therapy and used that as a dual antiplatelet therapy for years at this point. It works by inhibiting the ADP-induced platelet activation via the P2Y12 inhibition. However, we of course know that it has its limitations, including a wide variability in the response among patients, with some studies quoting an inadequate response to clopidogrel ranging between 4 and 34%. Clopidogrel also, of course, needs to undergo intestinal absorption and bioactivation by hepatic cytochrome enzymes and deactivation by esterases. And we know that this process of conversion from a prodrug to its active metabolite is not immediate, resulting in the delay in the absorption and getting that effective platelet inhibition. We can partially mitigate this, of course, by using high doses like 600 milligrams, for example, if we're dealing with a patient with STEMI. But we know that even that will take about 2 hours before the antiplatelet effect is truly where we would like it to be. And so these limitations over time have led to the development of newer and more potent P2Y12 inhibitors with more favorable pharmacologic profiles. And so both prasugrel and ticagrelor are kind of the newer generation P2Y12 inhibitors that are designed to overcome what we know to be the limitations of clopidogrel. Both of these drugs have higher efficacy when compared with clopidogrel and a stronger and more predictable platelet inhibition as well. We know that ticagrelor directly and reversibly binds the platelet P2Y12 receptor. And we know from the Plato trial that for patients that are presenting with acute coronary syndrome, dual antiplatelet therapy with ticagrelor and aspirin is more effective than clopidogrel and aspirin in reducing the 12-month combined endpoint of cardiovascular mortality, MI, or stroke, which was driven by significant reductions in that mortality and MI, and further kind of complemented by a significant reduction in death net or probable stent thrombosis. Prasugrel is an irreversible inhibitor of the P2Y12 receptor, and similar to clopidogrel, it is a prodrug that does require enzymatic transformation. However, compared with clopidogrel, prasugrel has a higher bioavailability and a stronger in vivo response with faster onset of action, more efficient antiplatelet effects, and less susceptibility to genetic polymorphism. In the TRITON-TIMI 38 trial, this study showed that prasugrel was superior to clopidogrel in terms of ischemic events in a large cohort of patients that had acute coronary syndrome. And then the ISAR REACT-5 trial has gained quite a bit of attention, as we know, and further suggests that prasugrel might even be superior to ticagrelor in reducing the thrombotic outcomes. However, we know that prasugrel, like every drug, also comes with some limitations, certainly contraindicated in patients with a prior TIA or CVA, and there's a lot of hesitancy in using this drug in an elderly population as well. So what we'll first start with is kind of a review of where our guidelines are at here in the United States. And this was most recently updated in the 2016 ACCHA Guideline Focused Update on Dual Antiplatelet Therapy for those with CAD. The main takeaways are really two things. It's a class 1 recommendation to continue dual antiplatelet therapy for 12 months after acute coronary syndrome. and 6 months after revascularization in the setting of stable ischemic heart disease. But we're going to look at the document a little bit more closely and take a look at the questions that they were asking at that time. So this update really looked at 3 major questions. The first question being, for patients that are presenting with stable ischemic heart disease, or ACS, compared with the 12 months of dual antiplatelet therapy, is 3 to 6 months as effective in preventing stent thrombosis, MACE, and how does it impact bleeding? And truly, they really ended up looking at just stable ischemic heart disease for this question. The second question that they asked was really the opposite. In patients that are presenting with that are getting PCI, is 12 months of therapy enough, or should we be continuing it for longer than 12 months? And how does that impact our mortality, rates of stent thrombosis, and bleeding? And then the last question that they asked is, for somebody who is presenting with a myocardial infarction, either a STEMI or an NSTEMI, is that a patient that we should really be looking at greater than 12 months of dual antiplatelet therapy for? So for their first question, like I said, what they really ended up looking at for this shorter duration of DAPT was for stable ischemic heart disease. And in the document, they evaluated results from 5 non-inferiority trials that were published between 2012 and 2015, looking at a shorter duration of DAPT, with the main endpoints being composite ischemic events and stent thrombosis. They found that these studies did not find any increased risk of stent thrombosis with the shorter duration of DAPT. And as expected, the shorter duration of DAPT resulted in fewer bleeding complications. Since then, we know that even more trials have evaluated this question. Oftentimes, these trials are industry focused for looking at their own stent. But we think at this point feel pretty comfortable with a shorter duration of DAPT for PCI in the setting of stable ischemic heart disease. The second question that the guideline update addressed was the opposite question. As opposed to cutting DAPT short, the question was really, is there a potential benefit as to the extension of DAPT? The primary question was whether extending DAPT would reduce late and very late stent thrombosis, as well as preventing ischemic events associated with disease progression. And they specifically looked at 7 trials that were published between 2010 and 2015, evaluating the utility of prolonged DAPT. Perhaps the most famous of these trials was the dual antiplatelet therapy study, which was published in 2014, took patients who were treated with dual antiplatelet therapy for 12 months and had no ischemic or bleeding issues during that time, and then randomized them to receive an additional 18 months of dual antiplatelet therapy, or had switched them to aspirin monotherapy. And notably, dual antiplatelet therapy in this trial was with aspirin and clopidogrel, or aspirin and prasugrel, and there was not a use of ticagrelor here, and it was the majority that were on the aspirin and clopidogrel regimen, about 65%. They found that extended DAPT had resulted in a 0.7% absolute reduction in very late stent thrombosis, a 2% absolute risk reduction in myocardial infarction, and a 1.6% absolute reduction in MACE. The prolonged DAPT also had a 0.9% increase in moderate or severe bleeding. And that brings us to our final kind of question. And essentially in the DAPT trial that I just mentioned, when they further investigated their results, they found that perhaps the biggest benefit was among patients who had presented with an NSTEMI or STEMI, a myocardial infarction, as opposed to those who had presented with stable ischemic disease. And so that prompted the researchers to think, well, should we be looking specifically at patients that have MI, and maybe they would be the best people to continue dual antiplatelet therapy in the long term for? And so I think certainly this question makes sense. We know that if somebody has had a prior myocardial infarction, that they have up to an 11% risk of having MI, cardiovascular death, or stroke within a year of their initial presentation with acute coronary syndrome. And we know that the high reoccurrence of ischemic events is thought to be related to ongoing platelet activation, even after they've stabilized from their acute coronary syndrome. And so when looking at this question, like I mentioned, the DAPT trial did suggest that there might be a potential benefit here. And then they further commented on a couple of other trials, the first being the Charisma trial. And this was a trial that looked at patients with established atherosclerosis or high risk of clinical atherosclerosis. And they randomized them to either receive dual antiplatelet therapy with clopidogrel or aspirin monotherapy, just as the name says there. And they found that with dual antiplatelet therapy, there was no significant reduction in the ischemic risks at a median follow-up of 28 months, but a 0.4% increase in severe bleeding. However, when they looked at the post-hoc analysis of patients enrolled in the study that had a prior myocardial infarction, they found a 1.7% absolute decrease in the composite endpoint of cardiovascular death, MI, or stroke events with the dual antiplatelet therapy. This benefit, however, was not there for those that had coronary artery disease without a prior myocardial infarction. And then the second trial that they looked at for this question was the PegasusTIMI 54 trial, which was somewhat unique in that it looked at antiplatelet therapy with ticagrelor. As you may have noticed, up until now, we've been mostly talking about dual antiplatelet therapy with aspirin and clopidogrel or aspirin and prasugrel. And in this trial, the patients who had a prior myocardial infarction were randomized 1 to 3 years after their myocardial infarction to either DAPT with the aspirin and ticagrelor or aspirin monotherapy. And they found that after taking a look at these patients after 33 months of therapy, that DAPT, when compared with monotherapy, had resulted in a 1.2 to 1.3 absolute reduction in the primary composite of cardiovascular death, MI, or stroke, and a 1.2 to 1.5 increase in major bleeding. But again, looking into that data a little bit deeper, those that had the greatest reduction in the events with the prolonged DAPT were those who had their P2Y12 inhibitor continued either right at the randomization, so at the 1 year mark, essentially not having any gap at all between stopping their dual antiplatelet therapy, or those that had had a gap for less than 30 days. And so essentially there was not a huge benefit in putting patients back on dual antiplatelet therapy if they had already been taken off of their dual antiplatelet therapy. And so collectively, these trials, plus the DAPT trial, like I mentioned earlier, did suggest that the benefit to risk ratio of prolonged DAPT is overall more favorable for those who have had a prior myocardial infarction, with an absolute decrease in ischemic events of about 1 to 3% at the cost of an absolute risk of bleeding of about 1% over the course of several years. And so this has resulted in this graph here, and it kind of puts things together nicely. It's a graph that we're all very familiar with, but for coronary disease, for those with stable ischemic heart disease who undergo a PCI with a drug-eluting stent, it's a class 1 recommendation to have at least 6 months of dual antiplatelet therapy, and the antiplatelet therapy should truly be aspirin and clopidogrel, since that's really what's been studied in stable ischemic heart disease. And then for coronary artery disease, with a patient presenting with an acute coronary syndrome that undergoes PCI, we know it to be a class 1 recommendation for at least 12 months of dual antiplatelet therapy. Here they do say with clopidogrel, prasugrel, or ticagrelor, but certainly we know prasugrel and ticagrelor are indeed better choices. And then if you look further down, it does say that if there is not a high risk of bleeding and no significant overt bleeding while they're on DAPT, that it's a class 2B recommendation to consider greater than 12 months of dual antiplatelet therapy, and that might be a reasonable choice. So really it depends a lot on how we're classifying our patients, either as being high bleeding risk or high ischemic risk. And so how do you do that well? As you can see, some of the same things predispose you to being both a high bleeding risk and a high ischemic risk. Advanced stage chronic kidney disease and diabetes will put you at increased risk of both ischemia and bleeding. But as far as where they separate, there is a higher risk of bleeding, or of ischemia, I should say, for somebody who has had multiple prior myocardial infarctions and has extensive coronary disease, and for those who present with acute coronary syndrome. We know that there's an increased risk of stent thrombosis among those who present with ACS, have a low EF, and then of course, if their stent is undersized, underdeployed, if it's a small stent diameter, for those that have greater stent lengths, bifurcation stents, and if there is in-stent restenosis. And then on the other side of things, for those who are high bleeding risk, those are people that have had prior bleed, those on anticoagulation therapy. We know that women are more likely than men to bleed, those who have a lower body weight, patients with a history of anemia, and those who are on chronic steroids or NSAID therapy. And we do have a score that can help us to weigh these risks of both bleeding and ischemia for our patients. We're all very familiar with, known as the DAPT score, which was derived from the dual antiplatelet therapy study that I mentioned earlier. This is a useful aid for us to help determine what patients should really be considered for prolonged DAPT. And essentially, it boils down to prolonged DAPT might be favorable for those with a high DAPT score, which is greater than or equal to 2, because prolonged DAPT reduces the net ischemic plus bleeding events when compared with aspirin monotherapy. Contrarily, those with DAPT scores that are low, the benefit to risk ratio of prolonged DAPT is not favorable. There's increased bleeding without a reduction in ischemic events. And so, as you can see, negative scores are given for age in that, the bleeding risk becomes higher with that. And then positive points where there is a higher ischemic risk are given to smokers, diabetes, patients with diabetes, those that have a myocardial infarction at presentation, patients with a prior PCI, and those with stent diameters less than 3. And as you can see, you get 2 points if you have CHF, for which they use the LVEF cutoff of 30% here, and for those with saphenous graft PCI. So these recommendations are put nicely into this flow chart here. And this is just for patients that do undergo PCI. Like I said, for stable ischemic heart disease, this is more of what we saw earlier, class 1 indication for at least 6 months of clopidogrel and aspirin for dual antiplatelet therapy, with a 2B recommendation for discontinuation if there is a high bleeding risk or overt bleeding, and a class 2B recommendation as well for considering longer dual antiplatelet therapy if there is no bleeding, no significant risk of bleeding, and perhaps a concern for ischemic risk going forward. And the same thing here with the acute coronary syndrome arm, class 1 indication, as we know, for the dual antiplatelet therapy for a 12-month duration. And similarly, consideration of longer dual antiplatelet therapy might be reasonable for patients that don't have a high risk of bleeding and may have a higher ischemic risk, and early discontinuation for somebody, of course, that might be having bleeding or has a high bleeding risk. And so we've looked at the idea of long-term DAPT, but more recently, a lot more attention has been paid to the idea of shortening DAPT. And how do we do that with different regimens? So we're going to kind of shift gears as far as where things have been more recently. And so what has changed in the last several years that have led us to this question? Well, we have more modern stents that are of course always improving. We have our better P2Y12 inhibitors, like we discussed earlier. We're perhaps even better at PCI as a result of our intracoronary imaging that can help us maximize our stent implantation. And we also add our drugs that help with secondary prevention as well. And I think that we're a bit more aggressive about using those as far as beta blockers, ACE inhibitors, and statins. And so now we've really gotten to the question of shortened dual antiplatelet therapy versus the de-escalation of DAPT, in which has, like I said, received a lot of attention recently. And there seems to be kind of a new study on this every day. So the question of shortened DAPT is kind of interesting because really the trials that I'm going to focus on and take a closer look at have to do with dropping the aspirin. And this question really came about in our patients that were studied that were on triple therapy. And so we for that, and then come for PCI, either in the setting of stable ischemic disease or having an acute MI. And so as a result, we certainly know that this has been studied in many trials, the Pioneer AF, the Augustus trial, and they've all led to the same question of how can we get patients off of triple therapy and get them onto a regimen with just 2 medications. And in those trials, the question repeatedly was, can we drop the aspirin? And so it led to the same question in patients on dual antiplatelet therapy of, do we really need the aspirin? And so, like we mentioned earlier, we know that aspirin irreversibly inhibits COX-1 and that aspirin interferes only partially with the inhibition of platelets. But we know that aspirin, comes with risk, as does any medication. It increases bleeding, both intracranial bleeding and extracranial, mostly in the way of GI bleeding. And then there's, of course, the fact that we have our more potent P2Y12 inhibitors. And some of these P2Y12 inhibitors already negatively modulate the production of thromboxane A2, having an aspirin-like effect themselves. And so it brings us to that question, do we really need the aspirin? So I'm going to talk about a number of studies that have been published more recently. This was the first study that was published really addressing this question that we're probably all pretty familiar with. It's the Global Leaders Trial. It was published in 2018, and it was quite a large study with almost 16,000 patients, in which the experimental arm consisted of patients withdrawing aspirin after 1 month and continuing ticagrelor monotherapy for the next 23 months. Versus the standard 12 months of dual antiplatelet therapy and then dropping the ticagrelor. Dropping the ticagrelor. Notably, they did not have a lot of ACS patients in the study. It was predominantly stable angina, with only 41% being acute coronary syndrome patients, and the majority of those patients had presented with an NSTEMI. I think that that's just an important thing to know when you're trying to interpret these trials and apply them to our patients. They focused on a primary outcome of composite of all-cause death and Q-wave myocardial infarction, and they saw that it was similar between the experimental and control groups, and that bleeding was also similar between the 2 groups as well. When they took each component of the primary endpoint, they did not find any statistically significant difference between the 2 groups. So overall, promising results, and have certainly led to a number of hypotheses and further studies that have looked at this question. And so a year later, in 2019, the Twilight Study came out. This was also evaluating dual antiplatelet therapy with ticagrelor and aspirin. And this study specifically enrolled patients that were thought to be either a high ischemic or a high bleeding risk based on kind of clinical and angiographic criteria. And they purposefully also took a higher percentage of acute coronary syndrome patients, not only with NSTEMI, but also with STEMI as well. Here, however, they looked at a primary endpoint. They looked at a primary endpoint of major or minor bleeding episodes. And so certainly they did find that there was a lower risk of bleeding, but that's truly what the study was powered to evaluate. However, when they did look at their efficacy endpoints, which was a composite of death from all causes, myocardial infarction and stroke, there was no significant difference as well. And then finally, this study also looked at ticagrelor and was a lot smaller. It's called the Tycho Trial. It had 3,000 patients, purposefully looking at 100% of patients that had acute coronary syndrome, including 36% that had STEMI. And they looked at a primary endpoint of a net adverse clinical event, which included death, myocardial infarction, stent thrombosis, stroke, but also did include bleeding as well. And they found that the experimental strategy of dropping the aspirin after a 3-month time period and continuing with ticagrelor monotherapy for 9 months did result in a reduction in the incidence of adverse clinical events. And that the experimental group showed a reduced risk of bleeding, which as we would expect, and also a similar incidence of the ischemic events as well. Like I said, their primary endpoint was a composite that did include bleeding. And then they moved on to looking into clopidogrel alone, and we'll kind of take a look at some of those studies. And so this Stopdapt 2 trial was published in 2019. Enrolled about 3,000 patients, and was designed to demonstrate non-inferiority of looking at clopidogrel monotherapy after 1 month of DAPT. The experimental strategy met non-inferiority and actually superiority when compared with the control in the reduction of their primary endpoint. The primary endpoint did include bleeding as well as cardiovascular death, myocardial infarction, verified stent thrombosis. They did show that there was similar outcomes as far as ischemic events, but again, the primary endpoint did include that bleeding arm as well. The SMART choice was a little bit more helpful than the prior study, the Stopdapt 2. This was a similar in size, but it included more acute coronary syndrome patients, about 10% of the patients having STEMI, and the primary endpoint was major adverse cardiac and cerebrovascular events. They did a longer duration of dual antiplatelet therapy, so they had done aspirin and clopidogrel for 3 months, and then had dropped the aspirin at that point and continued the clopidogrel for 9 months, compared with the standard dual antiplatelet therapy with aspirin and clopidogrel for 12 months. And here they did find that the experimental strategy was non-inferior to the control in terms of the all-cause death, myocardial infarction, and stroke. And of course, they found that the bleeding risk was lower in the experimental group when compared with the control group. And so putting these 5 studies together, it is a bit difficult since they all use different regimens and also different medications as far as their dual antiplatelet therapy goes. But there was one meta-analysis that did combine the results and essentially noted that discontinuing aspirin 1 to 3 months after PCI carries a consistent reduction in the risk of bleeding. And then in regards to, which is not a surprise, and then in regards to the efficacy outcomes, they found that discontinuation of aspirin did not lead to an increase in the risk of major adverse cardiovascular events, all-cause mortality, and stroke. And these results were also observed when the analysis focused on just those patients that present with acute coronary syndrome. So the next thing that we're going to kind of discuss is as opposed to shortened duration of dual antiplatelet therapy, what about the option of de-escalation of dual antiplatelet therapy? And so de-escalation of antiplatelet therapy refers to a couple of different things. First, it could be a transition from one of our stronger P2Y12 inhibitors, being the ticagrelor and the prasugrel, to a transition to clopidogrel after a certain amount of time, or it could refer to doing dual antiplatelet therapy with our normal doses, the 90 BID of ticagrelor and the prasugrel 10 milligrams daily, and then after a certain amount of time transitioning to a lower dose of either prasugrel or ticagrelor. So both of those kind of fall into this de-escalation of dual antiplatelet therapy arm. So just like when we looked at the shortened DAP topic, there have been several studies that have in some way looked at going about the de-escalation of dual antiplatelet therapy, and we're just going to look at a couple of them here. The first one worth mentioning is this Reduce As Our ACS, which was published in 2020 and was done in 35 hospitals in South Korea in patients that had acute coronary syndrome and underwent PCI. Notably of the acute coronary syndrome, mostly unstable angina, about 40% being a combination of STEMI and NSTEMI patients. And so they had taken patients that were put on dual antiplatelet therapy with aspirin and prasugrel. And for the experimental arm, they had taken the aspirin and prasugrel 10 milligrams daily for a month. And then at that 1 month time period had dropped down to aspirin and prasugrel 5 milligrams daily for 11 months, and compared that with the standard of the aspirin and prasugrel 10 milligrams daily for the 12 months. Primary endpoints was the net adverse clinical events of all-cause death, stent thrombosis, repeat revascularization, and did include bleeding as well at 1 year. And they found that the primary endpoint occurred in 7.2% of patients in the de-escalation group versus 10.1% of patients in the conventional group. And truly what mattered was that there was not a difference in the ischemic risks in the de-escalation group compared with the conventional group. Of course, the bleeding risk was significantly decreased. And from this, they had concluded that in this group of patients that they had evaluated with acute coronary syndrome receiving PCI, a prasugrel dose de-escalation strategy after 1 month of PCI reduced risk in net clinical outcomes up to a year, driven mainly by this reduction in bleeding, but without any evidence of an increase in ischemia. This was a bit of a different study, published in 2016. It was a small study, just 646 patients, all of whom presented with acute coronary syndrome here. And in the two arms here, all of the patients were put on dual antiplatelet therapy with aspirin and ticagrelor or aspirin and prasugrel for 1 month. And then if they were in the intervention group, they switched their dual antiplatelet regimen to aspirin and clopidogrel going forward. And this group was compared with the standard 1 year of DAPT with either the aspirin and the prasugrel or the aspirin and ticagrelor. Similarly to the prior study, they found that the primary endpoint occurred in significantly less of the patients in the switched DAPT group. Again, this was primarily driven by a decrease in bleeding here. You can see in the chart here that the net clinical benefit shows that significant difference, and again, was driven a lot, very much so by bleeding. But any ischemic event, cardiovascular death, and unplanned revascularization showed no difference as well. So now we've talked about two different types of ideas going forward as far as dual antiplatelet therapy. So is it best to go with a shortened DAPT regimen, or is it better to go with de-escalation of DAPT after PCI? And do we feel like we have enough information to make that decision? And again, are we generalizing this question to people that have stable ischemic heart disease or those that have an acute coronary syndrome? And so this was a meta-analysis that was published just earlier this year in JACC Interventions, where they tried to get a better answer to this question. The researchers took a total of 29 studies with the combined over 50,000 patients and looked at a primary outcome of all-cause death and secondary outcomes of net adverse cardiovascular events, major adverse cardiovascular events, and their components. And overall, the short DAPT trials were generally the discontinuation either of the P2Y12 inhibitor or aspirin at the 1 to 6 month mark. And the de-escalation, like we mentioned earlier, was either transition to clopidogrel after a certain amount of time of being on prasugrel or ticagrelor, or it was the reduced dose of prasugrel and ticagrelor ongoing, and compared that with the standard DAPT. And so the long and short of it is that they found that for patients with acute coronary syndrome who underwent PCI, that there was no difference in all-cause death between short DAPT and de-escalation. De-escalation reduced the risk for NACE, as you can see in the graph here, and major bleeding seemed to be favoring a shorter course of dual antiplatelet therapy. And so essentially what they had taken from this meta-analysis was that perhaps for patients that are at higher ischemic risk, a regimen of de-escalation of dual antiplatelet therapy might be more favorable versus those who are at a higher bleeding risk. Perhaps a regimen of shortened dual antiplatelet therapy is more favorable. So we have a lot of information, and really I've only touched on some of the studies that have been done. Like I said, this is certainly a hot topic that's in a lot of our literature right now. But of course, the real question is, how is this going to impact our guidelines going forward, and what's going to be recommended for us? And so the answer, I guess, as far as the ACCHA guidelines is that there hasn't been an update yet. But there was an update in the 2020 European Society of Cardiology guidelines, which I thought was worth mentioning. And so this is just a short clip of what the guidelines are recommending here, but this is for post-interventional and maintenance treatment in patients with non-STI acute coronary syndrome. And as you can see, that a strategy of stopping the aspirin after 3 to 6 months can be considered after stent implantation, depending on the balance of weighing the ischemic and bleeding risk as a 2A recommendation. And then they also include de-escalation as part of their guidelines as well as a 2B. But what it says is that de-escalation of a P2Y12 receptor inhibitor treatment may be considered as an alternative DAPT strategy, especially for ACS patients deemed unsuitable for potent platelet inhibition. So they have seen in their guidelines some reflection of what we've been talking about in some of the studies that have been done. And essentially, they focus a lot, as we all do in our day-to-day practice, on weighing the risk of ischemia versus weighing the risk of bleeding. For them, they use a precise a precise DAPT score, which factors in a patient's hemoglobin, their age, their white blood cell count, their creatinine, whether or not they've had prior bleeding. And they classify them as either being high risk of bleeding if they have a score of greater than 25. And then if their score is less than 25, it's thought that their risk would be lower for bleeding and that they might have a higher risk of ischemic complications. And so classifying their patients as that high bleeding risk or high ischemic risk, and then kind of going from there, they do have the options within their guidelines, like I said, as a 2A and a 2B, to consider either a shortened dual antiplatelet therapy regimen or for de-escalation. So that's certainly a lot of information. And like I said, I really have only touched the surface of a lot of what's been done more recently. But I still think that there are a lot of questions that are not answered at this point in time. And I'm not sure that we have a very good sense as to, what is truly best for our patients going forward. So, for example, if you do the short DAPT and do drop the aspirin, then what do you do after that 1 year mark comes for the long term? If you opt to go with the de-escalation, then how do you choose which pathway you're going to go with? Either sort of switching to clopidogrel or remaining on a lower dose of prasugrel or ticagrelor. How do you decide which is the best P2Y12 inhibitor for which patient? And then, should we continue to separate our stable ischemic heart disease and acute coronary syndrome patients? Because, oftentimes the studies don't, they include both, and it can be very hard to generalize those different types of patients. I don't think that the STEMI patients have been very well represented in a lot of these trials, and I would hesitate to say that that we know enough to really include them into what we know. How does the prasugrel fit into our drop aspirin regimen? To my knowledge, the only medications that have been studied with dropping the aspirin have been the clopidogrel and the ticagrelor. So I think that that's certainly a question. And how confident are we in that we know how to weigh the risk of ischemia and the risk of bleeding? We have the scores that certainly help us, but do we feel like that's enough to put our patient into the right category? And then, of course, it's worth mentioning that there are, of course, limitations to ticagrelor and to prasugrel. And I think we see this on a day-to-day basis just in our clinical practice. Ticagrelor is twice a day, which is very difficult for a lot of patients. It costs a lot of money oftentimes. It has the side effect of dyspnea. And then for prasugrel, contraindicated in a prior TIA or stroke, has the bleeding risk and should be used with a lot of hesitancy in an elderly population. So certainly I think that there are still many questions that need to be answered. And a lot of this information is going to have to be applied to your individual patient. So these are kind of the conclusions that I drew from doing a deep dive into this subject. I think at this point, certainly I still think that the guidelines that exist from our last ACC/AHA focused guideline update should remain true at this point, as far as dual antiplatelet therapy for 6 months for stable ischemic heart disease, 12 months for somebody who presents with an acute coronary syndrome using aspirin, ticagrelor, or aspirin and prasugrel. However, it might be suitable for certain patients to consider de-escalation or a shortened dual antiplatelet therapy regimen. I don't think that these suggestions are quite generalizable yet, and they're very much patient dependent. And we have not seen it reflected in our guidelines as far as an update goes quite yet. And I think, like I said, we just need to feel confident in putting our patients into either a high bleeding risk or high ischemic risk and feeling like we have applied, the individual patient to what we know with all of this data and information. So these are some of the references, and that's what I have for you guys today. Happy to take any questions or comments.
Thank you, Jennifer. That was a wonderful presentation. You really dug deep into all the various shortened DAPT and de-escalation trials, including the lesser known ones. So that was a really enjoyable and detailed presentation. Thank you so much.
Thanks.
So one question I had about, so shortened DAPT is essentially single agent P2Y12 trials, right? You did sort of go over a little bit about aspirin alone strategies, because there are some really small trials about that. One thing that I've faced in the clinic as well is about patients really wanting some sort of elective procedure. And if they're the ACS population, of course, it's going to be that they desperately want the procedure within the year. And I've sort of struggled with that a little bit. Do you have any thoughts on that? Because from the surgical perspective, most surgeons really consider the P2 white pill agents as the ones that they want the patient off of for surgery. And do you have any thoughts on that?
Yeah, I think that's super relative to our day-to-day life. And I certainly have seen many of the same types of patients. I mean, that's kind of, it's been the shift in the opposite direction of what's been studied lately, is to drop the aspirin. And so I haven't found any newer information or newer updated studies on diving deeper into just looking at aspirin monotherapy alone. But you're right. I mean, that is always the question from the surgical standpoint is, well, is it okay to just put them on the aspirin monotherapy? And I guess what I'm saying is that I don't have an answer as far as that goes. I don't know if anybody else has more information on that.
It's kind of this, Chris, it's kind of out of our hands, because the real rate limiting step at surgery is often the anesthesiologist and whether they're going to use some neuraxal block, subdural or whatever. And they follow their guidelines, which insist that they be off of the second agent, but do tolerate aspirin. So sometimes the only way the surgery will go forward is if we have them on aspirin alone.
Yeah. So there's a question from Amar, and he wanted to know if you have any specific thoughts on cangrelor.
Yeah, I mean, that's a great question. I have not used cangrelor very much, but I do think it's a great option for somebody that, of course, can't take PO. But I think that is, where it's somewhat limited. I think that in the cath lab is one area that we could do it, but perhaps for somebody who does need a surgery, like we were just discussing, that could be an option as well, of putting them on cangrelor in the short term and then going ahead with their surgery, knowing that we could put it back on after their surgery is over. So I personally haven't had any patients like that. I don't know if anybody else has, but I think that cangrelor is a great option for a certain subset of patients. I would say, of course, that subset's going to be mostly patients that are in the hospital, or only patients that are in the hospital.
And using it as a bridge for surgery, I think, would be a really expensive proposition.
I agree.
But I think the main use is obviously, in the acute ACS situation, patient is vomiting or unable to take P2 white pill agents. I've also observed and I've heard from some other friends that, folks are using it very just around PCI, and then putting patients on clopidogrel and sort of using that as, making for the advantage that the newer P2 white pill agents have. So that's obviously, again, unfounded practice, but that's another way of practicing as well that people have said.
Yeah, absolutely. That's great.
Hey, Jen, this is Steve Fowl. Thanks. That was a great review. A lot of people know I'm down on aspirin in general. And I think the evidence to support that we have to give aspirin, that there has to be dual antiplatelet therapy, is pretty thin. The only study, though, that I've seen examining aspirin-free angioplasty was a pilot trial from Japan a couple of years ago. I wonder if you're, in your reviewing for this talk, if you came across any news out there that there's any other aspirin-free trials that are being conducted or being planned.
Aspirin-free trials? Yeah, I mean, I think that's what, I think that is exactly what people are doing at this point in time. And I imagine that they're going to continue to keep on doing regimens of our more potent P2Y12 inhibitors and dropping the aspirin.
No, I'm talking about no aspirin at all. So a lot of
like without the 1 month bridge.
Yeah,
I see.
aspirin free completely. Because a lot of patients claim to have aspirin allergies, or a lot of people do have real aspirin allergies, and I think it's a practical thing. Plus, my own religious belief is that aspirin doesn't do much of anything. So, but I just wondered if you.
I don't know of any personally that are just going ahead without any short course of dual antiplatelet therapy, but certainly other people on the call may know more than I do about that.
Hi, Jennifer. Thanks for a great talk. So much information condensed. I have two questions. One is regarding the use of imaging, which is really the best antithrombotic we have in terms of preventing acute stent thrombosis, restenosis, late stent thrombosis, et cetera. It would be very interesting to look for a trial that included imaging and non-imaging, whether there were optimized stent results, because I believe if you do that, I really would have very little concern about
Okay.
giving
I
them
am
a
not
no
hearing
aspirin.
anything more. I don't know if
Right.
anybody else has any questions or comments, or if we should wrap up.
Yeah, I think that was a wonderful presentation again, Jennifer. Thanks so
Oh,
much.
I guess maybe I can't hear
Um,
you because it looks like you're trying to talk there, Kartik, and I'm just not able to
I got
hear.
my mask on too, so that doesn't help, but my mic is off.
Jennifer, can you hear me?
Okay, I can hear you now. Sorry about that. That was just a computer issue, it sounds like. Did I miss a question?
Jennifer, I had two quick questions. One is regarding imaging, because the reduction in thrombosis and adverse outcomes with imaging is fantastic and really a survival benefit now. I would have no problem giving an aspirin-free regimen to someone with an imaging optimized stent. I don't know if there's any studies on that. And the second question is the pendulum of genetic testing. It's gone back and forth and back and forth. Do you have any comment on that?
Yeah, I mean, certainly as far as the genetic testing goes, it still is not recommended to go ahead with genetic testing. And I would imagine that as we're shifting away from using clopidogrel, that they probably won't do any further investigation on that, to be honest. But at this point in time, you know, the guidelines don't recommend anything as far as that goes for routine testing for patients. And I agree with you totally as far as the imaging factor. And I think that that's why we've really developed these questions to begin with, honestly, is that we are, as far as PCI goes, we are doing a much more optimal job as far as using IVUS and OCT to really understand, you know, how to make sure our stents are as optimal as possible. And I think that I haven't seen any trials that have like specifically looked at, you know, imaging versus not imaging, and then dual antiplatelet therapy and not using dual antiplatelet therapy for long term or anything specifically like that. But some of the trials that I did read in preparation for this talk would often comment on the amount of imaging that was done. For example, one study had said that they felt very similarly to what you're saying, very confident in taking off that aspirin very quickly because they had a very high percentage, like over 80% of using either IVUS guided or OCT guided PCI. So I think that only adds to our confidence in taking off another antiplatelet regimen if we are using imaging guided PCI.
It's weird.
All right, we're at the hour. So if there are no last questions, we can close for today. And thanks, Jennifer, again. That was a wonderful presentation. I truly enjoyed it.